we are going to talk about the instruments commonly asked in the exam related to tonsillectomy and a few instruments regarding the esophagoscopy, bronchoscopy and the laryngoscopy. Okay, so the first thing that before we start, we must know what is commonly asked in instruments. So whenever you are asked about an instrument, you are supposed to tell the name of the instrument, number one, the common uses of that instrument, and if possible in which step of surgery it is used, and number three, you are supposed to tell the correct way how it is held. So these are the three important things the examiner wishes to know about the instrument from you. Okay, and very commonly you are asked instruments related to tonsillectomy. So we'll start with that. Okay, so briefly, this is Boyles Davis mouth gag. All right. So Boyles is for the blade. B for Boyles, B for blade. Okay, these are different sizes blades, and this jaw guard is called as the Davis gag. So together they form the Boyles Davis mouth gag. How it is, where it is used? It is used in various surgeries related to the oral cavity, the oropharynx, the hypopharynx and the nasopharynx. Now what all are those surgeries? They can be surgeries related to the palate, like cleft palate surgeries, palatoplasties. Okay, these are the surgeries, or you can do surgery on the uvula. So there is something called as uvulopalatopharyngoplasty surgery. Then in the oropharynx, commonest surgery is tonsillectomy. For nasopharynx, you've got the commonest surgery is edenoidectomy, or even juvenile nasoangiofibroma through transpalatal approach and pharyngoplasty. Okay, and for taking biopsies and all. Only limitation of this instrument is that you cannot do any surgery on the tongue floor of the tongue. Because why? Because it sits on the tongue. The blade sits on the tongue, so it is not exposed. And how it is used? You have to press this lock and insert the blade. Okay? And then after this, there is these three instruments which come in use later on. You first introduce it with the closed thing inside the oral cavity and the mouth. Okay, with the patient lying supine or in the rose position at the neck. The mouth is opened, the tongue depressor is placed over the tongue, and the gag part goes over the upper incisors. Then you, with this other hand, you gradually open this mouth gag. So the tongue will go up and this will stay locked, and you will get the space to operate. After this is opened, so to free your hands, you will have to use these two prong like things which is called as the Draffin's bipod, and you fix these pods on this plate which is called as the Magorran's plate. Okay, this is called as the Magorran's plate and the Draffin's bipod. So your assistant helps you in putting this like this. I'm trying to fix it myself. Okay, so the lock might have opened, but this has to be locked properly, otherwise this will keep slipping. Okay, and this goes under the shoulder, and this is how it is placed. Okay, so I have to hold it like this, but once it is fixed, because of the counter traction, you don't need to hold it any longer. All right, and then you can easily operate in that area. and according to your requirement, based on how much space you want, you can open it up even more, right? And the operator, the surgeon, sits on the head end. So in front of me now I have the vision of the entire oral cavity, the oropharynx area, and the soft palate and the base of tongue area. Okay, so this is how you use this instrument in conjunction with these two instruments more. So Boyles Davis mouth gag placed on the Draffin's bipod and fixed onto the Megorans plate, which goes under the shoulder of the patient. Okay, so are we clear? And this is how it is held. So we've answered this first instrument. Now we go on to another instrument which is commonly used in oral cavity, oropharynx and nasopharyngeal surgeries like tonsillectomy, adenoidectomy, palatoplasty, pharyngoplasties, right? Or even biopsies of the oral cavity, oropharynx and hypopharynx. This is called as Yonkers suction cannula. So you can see the girth of it. The cannula is very wide, so it can suck lot of secretions at the same time. This is held by your assistant and helps you in giving focus at a clear vision at the point where you are operating, right? And it is an atraumatic one because it has got suction on the side and on the front, and it is blunt. So it's an atraumatic suction cannula. Okay, and the suction tube is fixed at the other end, right? Another instrument which is used commonly for tonsillectomy is molluscens anterior pillar retractor with tonsillar dissector. So this blade part is the dissector. It's a blunt dissector. It is not sharp, and it is held in a pen holding manner. You are supposed to hold it in a pen holding manner, and this you hold in the right hand, and with the left hand you hold another instrument which is called as Dennis Brown tonsil holding forceps. Why is it called tonsil holding forceps? Because the ends of this instrument are not sharp, they are very blunt, so it will just barely hold it. This instrument can be commonly confused with the Lux forceps, which is used in the nose surgeries, nasal surgeries, but there is a big difference that this is very broad. So whenever this instrument is kept in front of you, you are supposed to see the broad holes of this instrument. So tonsil, a big O is formed in it. So this O is the tonsil. O of the tonsil is, this is how you remember this instrument. Okay, Dennis Brown tonsil holding forceps. And the fulcrum is also very small in it. Whereas in a Lux forceps, the fulcrum is very long and the entire blade goes inside. This doesn't go inside, it sits on it. Okay, so small fulcrum, the blades, the two pieces sit on top of each other, and there is a big hole in it, and it is not sharp. So these are the identifying points of this Dennis Brown tonsil holding forceps. You hold the tonsil, the upper pole of the tonsil, and once you hold it, you retract it, and then gently this dissector is introduced inside, and you break the bands, the mucosal bands or the fibrous bands which lie between the tonsillar capsule and the anterior pillar. Okay, the anterior arch. So this is the tonsil, this is the arch, this is the uvula. You hold this with this instrument like this, and you retract it out. So this space that is created in between the capsule and the arch, you put your dissector inside that underneath the anterior arch of of the palate, and dissect out and open up and take out the tonsil and dissect it all the way up to the inferior pole. Okay, so once you have dissected it out, you reach to the inferior pole, then you take up another instrument again in your hand, which has to remove which side of the tonsil it has to be removed, is this eaves tonsillar snare. So now this snare has got a wire in it, which is of approximately 25 gauge wire, right? And this is supposed to be, the tonsil is supposed to be looped. You take out the tonsil from inside this, holding the tonsil, and you go all the way laterally to the end where the inferior pole attaches near the base of the tongue in the tonsillolingual sulcus area, and you gently press it so that it crushes and then finally cuts the tonsil hole, right? So this is a crushing and cutting instrument. First it crushes it to achieve hemostasis, and then finally it cuts the tonsillar tissue at the inferior pole. So this is an eaves tonsillar snare used for crushing and cutting the tonsil while tonsillectomy. Okay, so once you have removed the tonsil, now you pack the tonsillar fossa, the bed. Now you need to inspect your tonsillar bed. For that, again you lift this instrument, the molluscens retractor. This will retract the anterior pillar. Once the anterior pillar is retracted, so you are holding it in a pen holding manner. You retract the anterior pillar, you can see the tonsillar bed, and you look for any bleeders, and then you use this Burkitt's straight artery forceps, which will, if there is any arterial or vessel bleed, you will just straight away clamp onto it like this, and you lift it up. Once this is lifted up, with the other instrument, which is the curved Burkitt's forceps, artery forceps, you go underneath it and you clamp it and you remove this. So now you have the mouth clamped and you can see the mouth of the bleeder. And there is another instrument which is called as the Negus knot director. So you take a knot and you direct it underneath it. You have to loop that knot around this bleeder and then pull it up gently and tighten it. Once that knot is tightened underneath the bleeder, then this artery forceps is released. So you can ligate the bleeders. So these two instruments, the Burkitt's straight artery forceps and the curved artery forceps, is used for ligating the bleeders in the tonsillar bed post tonsillectomy. It can also be used in other places in the oral cavity where the depth has to be worked in. Okay, so you can hold bleeders with it. It's mainly used for clamping the bleeders, right? So once your bleeder is clamped, you have achieved your hemostasis, your tonsillectomy is complete. So that finishes mainly the instruments that I use in tonsillectomy. And if you need to see the entire stepwise detail of tonsillectomy, you see the video that I have posted already, right? Another instrument which is commonly asked is this St. Clair's Thompson edenoid curate with guard. Now this instrument is used for adenoidectomy surgery, and you are supposed to hold it in a dagger, like a dagger. This is how you hold the instrument, and this is the blade that shaves it. This is the curate part and this is the lock. Okay, so when this is introduced into the nasopharynx, you go back When you are sitting as an examiner on the head end, this instrument is pointed at the back like this. So you gently go beyond the uvula, gently press on and go inside the nasopharynx all the way up to the posterior end of the septum, okay, all the way up. Then you press on to the adenoid tissue that is there, and this lock will lock the adenoid tissue. The position of this instrument has to be in the midline, and when you are withdrawing this instrument, you have to take care in the fact that you have to flex the neck to avoid the subluxation of the joint or excessive trauma to the nasopharyngeal mucosa. Because if you press hard and you don't flex it, there will be more trauma to the cervical spine and to the joint as well as the mucosa, and you will cause more bleeding. So it has to be gently flexed and withdrawn in the midline with a gentle pressure and lifted off moment you reach the lower end of the soft palate. You lift it off and you will have the adenoid tissue clinging on here. The use of the lock is to prevent the slippage of the tissue into the oral cavity and the oropharynx and down into the larynx. So it avoids aspiration of the adenoid tissue. So this is the use of the lock, and lower part is the curate part, which will gently shave off the adenoid tissue. Okay, then you've got another instrument where you don't have this lock. So that is meant, which is only the curate part without the guard. So this is St. Clair's Thompson's adenoid curate with guard, and you have another instrument which is without the guard. There you will only have this curate. That is only used for removing the residual adenoid tissue on the lateral aspect, which are near the nasopharyngeal end of the eustachian teeth. Okay, so that's a more gentler instrument, and you only remove small tags. Okay, so this instrument is the most important instrument for adenoidectomy. Rest of the instruments are more or less the Yonkers suction cannula, the Boyles Davis mouth gag is almost the same. So with this instrument you remove the adenoid tissue. Okay, so we complete this instrument. Now we come on to a set of instruments. What is this? Now this is, as you can see, this instrument has got two slots. These are for the ventilation of the opposite side of the bronchus. So this is a bronchoscope. So how do you recognize a bronchoscope? It's a long tubular structure, okay, approximate length maybe around 20-25, okay, and it has got ventilation tubes on both the sides for the opposite bronchus. So it is, and this is the light carrier system here. Then you've got the suction attachment here, and this handle tells you about the point, where is it pointed. So once this is inserted inside, you really cannot understand which side it is. So this is like a guide. So you angulate it at 90 degrees when you have to negotiate it through the vocal cords, and you have to visualize the ventricles of the cord, that is the space between the false cord and the true cords. So if you have to do a diagnostic laryngoscopy or bronchoscopy, you go through it and you visualize the ventricles, and that is how you visualize the left, and then you rotate it again by 180 degrees to visualize the right ventricle. Ventricle is the space between the true cords and the false cord, the vestibular fold and the ventricular fold, okay, cord, okay. And the uses of this instrument: diagnostic use is to evaluate the bronchus, the main bronchus and the secondary bronchus, okay, and even the trachea. So for any growth or any hemoptysis, patients who have got hemoptysis, or you are having suspicion of a foreign body. So those are the diagnostic uses. Therapeutic use, most commonly it is used for removal of foreign body bronchus or for taking biopsies and tissues or any benign growth of the trachea or the bronchus, right? And the ventilation is when you are for the opposite bronchus. So if you are on the right, the left side is ventilated, all right, and when you are in the left, the right side is ventilated. Okay, common questions you will be asked, which side foreign body is lodged more? So it's the right bronchus. Right bronchus because it is more wider, it is more shorter, and the angle with the trachea is only 25 to 30 degrees. So there is more chances of lodgement of the foreign body in the right bronchus compared to the left bronchus, which is longer and more angulated and narrower. Okay, so this is about the bronchoscope. I am clear about it. Then commonly instrument that is confused with this is the another broader long tubular tube, which is the esophagoscope. Easy way to differentiate between the two is that it does not have any ventilation tubes because it is going inside the esophagus, and it has got a broader tip, and you can see the markings up to 40 centimeters starting from here. So this markings indicate we have to know the esophageal constrictions from the level of the incisors. So you've got at 15 centimeters, you will find the cricopharyngeal, which is the narrowest part of the esophagus, right? Then at 25 centimeters, you will have the aortic arch constriction. Okay. Then at 27, you will have the bronchial constriction. And finally at 40 centimeters, you will have the lower esophageal sphincter constriction, where the esophagus joins the stomach, right? Esophageal gastric junction. So that is at 40 centimeters. So that is how you measure. So measurement is for evaluating the constriction at what level you are from outside. Again, this will guide you the bevel. So this bevel is on the lower side when this is on the upper side, similar to the bronchus. So you know how you have to turn it. And this is your light carrier, and suction you port doesn't have, you have to put the suction when you have to clear the secretion through the main hole, which is the tube of it, right? So this is an adult one, and then you have got pediatric esophagoscopes also. So this is about esophagoscope, and this is for rigid esophagoscopy. Diagnostically, you can look in for any growth in the esophagus, patient who got hematemesis, bleeders in the esophagus, right? Or you are suspecting any growth there, or foreign body esophagus removal is the therapeutic role of this, or you have to cauterize the bleeders in the esophagus, right? Esophageal varices you have to cauterize, that you can do with this, all right? Or you can take even biopsies of the growth, suspected growths in the esophagus, and at what level you are, you can see with these constrictions. Okay. Another it can also be used for esophageal dilatations for introducing the bougies, right? In cases of eclasia and all, right? Or any benign constricture because post injury or post use of any corrosive or anything. So if you are suspecting any kind of stricture, you can even use for dilatations, right? Then this is your laryngoscope. This is called as the Negus anterior commissure laryngoscope. Why? This is the light carrier, this is the area through which you visualize the larynx, and this is the handle, and this is how you hold it. All these instruments are introduced in a dog barking position. where there is flexion at the neck and extension at the atlantoaxial joint. Okay, like this. Mouth widely open. Gently you introduce, go up to the level of the base of the tongue, lift the vallicula, and you introduce, and you are able to see the false chord and the true chords right in front of you. So this anterior commissure is specially advantageous for visualizing the anterior commissure, because this anterior commissure is a part of the larynx which is not easily visible with the indirect laryngoscopy or with the video laryngoscopy. So if you have any growth or any polyp at the anterior commissure, that has to be, you have to use an anterior commissure laryngoscope. So this will give you an idea about this is one of the hidden areas of the larynx. Okay, other hidden areas are as I told you, the space between the true chords and the vocal false chords, right? That is also or the undersurface of the vocal cord. That also is an hidden area of the larynx, or the apex of the piriform fossa, or the subglottic region, and the laryngeal surface of the epiglottis. And you get your picture on the monitor, and you can easily see your entire vocal larynx with this. So it is called microlaryngeal procedure or microlaryngeal surgical procedures. Okay, so this winds up with your, and this handle, you've got a suspension to it which is attached here, that is not here with us, and it is put on with a chest piece. So that chest piece can rest on the patient's chest, or it can be suspended by a suspension laryngoscopy system. So that is called as suspension laryngoscope. Okay, so that there is no pressure on the chest. So there has to be one more attachment to it. You can't just hold it like this. For procedures which are short, 2 minutes, 5 minutes, you can hold, look, and diagnostically you can take a biopsy and come out. But if you have to do a surgery, it has to be fitted with that chest piece to hold it in its position, and both your hands are free. Alright, so this completes the common instrument used in tonsillectomy, adenoidectomy, bronchoscopy, esophagoscopy, and laryngoscopy. The question: accents, anterior commissure, laryngoscope. This is just a rigid bronchoscope, that is what you call, and this is a bronchoscope. This is the rigid esophagoscope. Sorry, I just got confused, but this is what it is, right? And these are the other instruments that we already talked about. So I think we are done with it. Thank you.